Okay, tidbits with Mickey. I'm gonna two parts for this. So first thing I want to do is explain this QA QI stuff that's going on with the medical director and some meetings we've been having and what it means for the district and what it means for Berrytown. Some of the stuff in this training or this video rather is going to be Berrytown specific, but there's some learning points for the greater good. And I guess I should just caveat that some of these are my opinion. A big portion of this is going to be report writing. There's going to be a lot of similarities and overlap drawn between report writing and the QA/QI process. So I just want to start by saying that some of this is my opinion. This is how I personally write. It's a style. It doesn't mean that it's right or wrong and that anybody else's is right or wrong. But I'm just going to extrapolate on a couple of topics and big ticket items with report writing that I think are important, and then hopefully they can benefit some other people as well. So with that being said, I'm going to just briefly talk about the QA/QI process, what it means to me. So I think there's quality assurance and there's quality improvement. So when we systematically review performance, documentation, so that's by SIREN, and the outcomes associated with that, so what the patient outcomes are when we do follow up, it's to ensure that standards of care are being met. And for us, that mostly means protocol adherence. Quality improvement adds a layer on top of this by using the insights that we gather through quality assurance to then make more meaningful, reasonable, data-driven or evidence-based changes that enhance the patient outcomes and also the operational efficiency of the service. So like I said, for us, I'm talking mainly about Berrytown, but collectively, this applies to every service. So to understand QA/QI, I like to kind of phrase this as a cultural shift towards understanding the process and towards providing excellent care, as a combination of not only guidance that's provided from the top level down, but also at the individual level up. So if you think about it as a pyramid, no top of the pyramid stands without the bottom building blocks, and no pyramid is complete without every single part of it. So, I don't ever like to separate levels here, but in essence, every single little building block of any pyramid, no matter where you fall in the pyramid, is important. Otherwise, the structural integrity of the pyramid is not as sound as it would be if everybody's on the same page. So one of the main topics of this video that I'm making is to get everybody on the same page. So with that, I'm going to briefly explain what this process is. There are some additions that the state is making to training in general, so I'll touch on that, and then I'll just give an example of my thoughts about how to write a run report. I'm not going to be able to encompass everything I want to say in this one video because there are short run reports, there are transfers, critical care runs, critical incidents, incidents involving multiple patients, incidents like cardiac arrest that have a lot of care provided, and then there's lift assists. So I can't encompass every single type of call there is out there, but I can at least provide some sort of like framework and, oh, okay, now I understand a little bit about, better about, but the where I'm at least, change the thought process a little bit. So the metrics gathered through the QA/QI process, very important. So those are what guide protocol updates. And with everybody around us that complains about, oh, this protocol's stupid, or this should be this way, or this should be that way. Well, I tell you, it takes evidence, it takes data, and it takes commitment and dedication from the people who are to do that work, to then present it with the stakeholders that can make the effective change. So in order to do that, we need metrics. You can't do any of this process without metrics. How do you get metrics? You correctly and accurately document all of the information necessary in the run report in order to gather those metrics. So if you ever find yourself thinking, boy, this is stupid, and then you reflect on it and you say, maybe I'm not providing as much data as I need to towards these metrics, then even though it's not intentional, you're actually kind of part of the problem. So metrics guide protocol updates. They influence training priorities, which is a huge priority for me, and they keep the evidence-based practice at the forefront of what we do in medicine. So metrics alone, though, aren't enough. They're only designed to understand trends. How many IVs were missed this quarter? How many stroke alerts had a 12 lead done? Those metrics individually don't tell us anything about the totality of care that was provided, whether 10 out of 10 reasonable practitioners were consider it good, standard, or substandard. Um, So we're understanding trends by the metrics, but it's not a complete picture of every single 911 call or transport. That's important because QAQI cannot entirely rest on one person's shoulders. Right now, I kind of do it. But it would be better if everybody provided a QAQI outlook on every single run report that they wrote going forward. Then it would be spread across everybody's shoulders, and we would have this cultural change, and you would see improvements without actually directly saying, hey, Bob, or hey, Susan, I need you to improve on this. If the culture changes, then you would see changes around you in your organization without actually directly having conversations about it. So it's not feasible or sustainable to have one person or even a couple people do QA/QI, particularly in a busy agency like Barrytown, where there's a really high call volume and there's a large amount of staff, and it's only increasing. And that's probably a common theme between all services around us. So doing justice to the complexity of every case would require multiple full-time positions solely focused just on the chart review and system analysis process. Um, Instead, the more, I guess, long-lasting change happens when an organization in a totality, or as a whole, embraces a culture of QA/QI, where every single employee, from all of the field providers to leadership, begins to think in terms of quality, and then the culture shifts to create an environment where feedback is not feared in terms of like reprimand, which is a historic problem in EMS, in my opinion, but it's welcomed. And there's, instead of being defensive, it's more of applying change and self-reflection with confidence and an enthusiasm. So to share this goal collectively provides better care to everybody in the community, not just the individual that's critiquing or getting critiqued. So recommendations need to be considered thoughtfully, not defensively, I guess is what I'm getting at. So by adopting this mindset, this philosophy, whatever you want to call it, a lot of QA/QI process starts to happen sort of organically or subconsciously, and crews begin to write runs clearer. They begin to reflect on their own care that they provide as if somebody is reviewing it. Um, they they write more accurate run reports, and then they also include more pertinent information, knowing that metrics are only part of the problem, but creating a run report that encompasses the totality of a situation rather than just what's a red box on SIREN helps to facilitate the overall process. So the increased ownership that's required from all staff members and their care, that's what drives this reviews process. That's what drives the change in culture to become less about correcting action and more about collaborating to collectively improve. So instead of thinking, oh, these are my faults, it's worth people just understanding that nobody's perfect. And for every fault that you have, you also have um, a strong point or something that you can provide to other people to facilitate their knowledge gaps. And when everybody collectively does that, then an organization builds together. And I guess without sounding too mushy, that's what I'm trying to get at. It's also critical to acknowledge the limit of data. So a lot of the conversations that I've had in it regarding this and through a handful of meetings have been, oh, just use artificial intelligence, or just use the SIREN report writer or the CQI software that's built in there, or use some sort of technology. That's great. That can help extrapolate pure intrinsic data when everybody provides 100% the same data the same way every single time. And we know that that's not true because not all boxes are read and not all people write run reports the same. And you can't stand behind somebody and force them to write a run report the exact same way every single time. If you wanted to do that, you would just need to go on every single call by yourself and then also write every single run report by yourself. So software, AI, algorithms, those are valuable tools for compiling data, and they can highlight overall trends. For example, why have we missed first time success rates on passing tubes on an intubation attempt? Why did we go from missing 15% of first attempts to 48% first attempts? That would be a huge CQI measure to get to the bottom of. So we could highlight stuff like that, but the context of the call and the reasons why, would not be reflected by that CQI measure. Did we just change intubation equipment, which, surprise, we have recently had new Interbright the UA scopes, and now we're getting 3 more in a couple of months. So the QA/QI measure that you're going to get is not going to tell you that a service has changed the modality of intubating. That requires somebody's eyeballs to extrapolate that information on their own interpretation. So ultimately, you can't capture the full nuances of every single call and service level details using just software. So the clinical judgment, the human elements, the totality of the call, the weather, the surroundings, the conditions on scene, all of that relies on a quality review in the context of a personal interpretation that only trained people can provide. That being said, not every person that is considered a trained professional will provide the same feedback or same outlook or review or interpretation of a call. So there also has to be collaboration on behalf of the team that analyzes these calls to make sure that even though they can't do things 100% perfectly in the exact same way every single time, that at least there's a shared vision and a shared understanding of how to approach QA/QI. With that comes the awareness of the overall process, which is what I'm trying to highlight in this video. So the goal is not to be perfect, but to have consistent improvement. We want to say, how can we make this process easier for the reviewer? So when you write your run report or you provide care, obviously your focus should be the patient in front of you, but you should also have this thing in the back of your mind, this cultural shift, this like change in your thinking or philosophy, or however you want to phrase it, that says, how is what I'm doing right now beneficial for the patient, beneficial for who's going to read my run, beneficial for the hospital, beneficial for the organization? How are we as an organization, a collective unity of factors moving in the right direction versus just me doing this run because I want to get home and go back to bed, or just me writing this run report because only 9 things say that they're read and I have to fill them out and I don't have to go the extra mile to fill out a couple other things that would make the process better. So that starts with better documentation. I think everybody needs to kind of renew their commitment to the professionalism of VMS in general and provide that level of, is renewment a word? That commitment needs to be reflected in your run reports. And then that takes a cultural shift, which I've mentioned a couple times so far in my blabbing. So you have to reflect on your actions, reflect on your decisions. You have to engage in conversation with other staff members. You have to have a degree of curiosity to wonder, well, maybe if I did this, would this have been better? And then you have to pursue that curiosity, and you have to have a shared responsibility for high quality care. And if every single person in the organization doesn't do that, then you're going to be held back. So it's not about complying with a QA/QI process. I tried to get everybody to do collective run reviews so everybody could sort of dip their toes in and see, like, it actually is easy to review a run and it's easy to pick up on people's mistakes. And then it's also easy to not understand what happened on scene because you weren't the person that was there and you weren't the person that was writing the run. So I wanted everybody to have a shared understanding of what reviewing and receiving critique was, but it didn't really come to fruition that well. A lot of people kind of just stopped doing that. So whatever, that was on you, not me. So that being said, I think a lot of this comes down to having pride in your work, having integrity, also that integrity has to be reflected in your documentation, and then how you can have some sort of common belief in the service you work for and the people you work around, and then how you are all improving medicine together. So that being said, I'm going to do, oh crap, I am not sharing my screen. That's okay. Doesn't matter. I haven't really shared anything. Screen. Entire screen. Haven't really gone into the weeds yet. Okay. 2 things left, and then this training is done. Yep. So this form, state approved agency training documentation. I can no longer go in and just pop out trainings for people on Vector. I can no longer go in and just pop out, all of our training was recorded. It was all very much exceeded what you would consider a standard. So if audited, no big deal. But now there's this state level provided training that Courtney's been working on, this documentation form. So here's what it's going to look like. Agency name, I'm going to fill one out for tonight's training. Berrytown EMS, data training, 06/04/2025. Topic, QA, QI, oops, and report writing. Duration, we'll say 1 hour, maybe 1.25. That's okay. Name of individual delivering. That's me. Approved number of CEOs. 1 CEU. I think I could probably click any of these. I'm not a national educator, so I'll probably just do individual with this one just to be safe. Description of training. QA, QI process, the culture of quality improvement, trends in, that's a bad way to say it, the philosophy of no, that's not good either. Let's just stop there. QA QR process, the culture of quality improvement, and its reflection in report writing. Objectives. By the end of this, better understand the QA QI process and what it means for all of us. How to apply the QA QI process to provide better care and make better suggestions. Ooh, that sucks. I did not I actually put in these boxes myself. So how to apply the QA QI process and provide feedback to others, right? And then lastly, report writing tidbits with how to improve the QA QI process. We're going to build a run together. I'll submit a certificate of education. If somebody doesn't work for Berrytown, I'll send you a certificate with this, like I always do, and then I'll put everybody else into Vector. And then here will be the names. So if you say, yep, I reviewed your whole thing, I'll give you a yes. I'll upload this, and then I'll sign. Ka-chow. So that's that. So this is gonna be required for every single training going forward. And then let's build a run together. Like I said, I can't do that to like every single thing. It's just gonna be way too much, but I will create one run. I'll make it pretty middle of I won't make it critical care, but I won't make it basic no load either. So create new run. Hopefully David can delete this later. So, and then here's a recommendation that I have for everybody else too. I'll show you this once we're done with it. I'll come back to this again once we're done. If you are a QA QI reviewer and you're looking, like, remember I said data extraction and algorithms and technology can't do all of this. So how can you make the process quicker and smoother for you when you actually put your eyeballs on a run and you do a whole case review? Because that's obviously required with high stakes calls that you want to do training on, calls that get a lot of optics, like, the big ones, right? Fires, big car accidents, stuff like that. Cardiac arrest, stroke, trauma, whatever. So if you fill out your run, or whoever fills out their run. And then you go back to the home page, and like I said, I'll come back to this, and then you ensure that it's locked. That's really important. I like to do that. I always lock a run when I'm done, because it just shows that anybody else that goes in, if they're a QA/QI reviewer, they're viewing the run for QA/QI purposes. Of course, you can always pull a de-identified QA/QI run, but for me, I write my runs the exact same way every single time, so I'm used to that flow. And if I'm used to that flow, the flow is quicker when I do it the same way every time, including when I do it during the QA/QI process. And if you're really curious about it, you can always go into here and then add an addendum, and you can say reviewed for QA/QI purposes only. So let's just say we'll call for chest pain. Let's just say 64-year-old male, sudden onset chest pain that woke them up at 3 in the morning. And you don't recognize the address, so it's not a repeat caller, and we're going in. So it's a 911 call. Is cardiac in here? Heart AICD problems. There we go. Incident number. Pretend, what do we want to call this? We want to call this an example run. And so I can find it. I'm going to do 2025 dash a run that we haven't gotten to yet. Yep, that way it'll be right on the top. There we go. Response. And then, actually, never mind. I'm going to get to that. Berrytown 3, capability of unit. And this just becomes so quick. Like, let's see, when did I start this? At about 9:02? We'll see when I finish. ALS, paramedic, crew member. Me. We'll just say me for now. I was the let's just say I was everybody. Let's just say we're a coverage crew, and we went with lights and sirens. Even though it's 2 in the morning and there's nobody around. Home address 123 Smith Street in Barrie. Scene. We were the first on scene. As we go through this, I'm going to click all the generic stuff, but then when we get to stuff that's specific, that are like key highlights to me when I write run reports, I'm going to talk about them. Patient contact made, care provided. Let's just say their initial acuity was unstable, because when we get to them, they're going to be pale, sweaty, and they're going to be like, ouchies, my chest hurts, and then they're going to vomit. So we initiated care. We transported them. You know what? Let's just say they didn't, but they could have a VFib arrest. Let's just say that they're unstable, and then let's just say for STEMI, I don't want this run to be, I don't want an alert for this run to be counted as a STEMI, but let's just say it's going to be a STEMI, but I'm going to say inconclusive. But I would say yes there. But I don't want some office to count this as one of their STEMIs. Unknown injury. Requires reportable condition. I don't know. I would like to think that somebody would click one of these if it was actually applicable. And was it a school-related incident? 99% of the time that's no. I leave this blank. But I think if it's yes, you should probably click yes. I think these things are probably tracked. And where did I mess up? Oh, yeah, it needs me to have one more. All right, who am I working with? We're with Jack Wagon. She's had a recent out-of-hospital STEMI cardiac arrest. So let's do that. Okay. So last name, Smith. And then first name, Smith. And then date of birth, 01, I don't know, 1961. How does that make them? 64. I think that's what I said. They're a male. I always put not applicable here. I don't know. Do what you want. But for me, that doesn't matter. But it is a red box. I always put the hospital record number, whatever that may be. It's not that much work to do. It's on the face sheet, and I always put their phone number. This helps with long-term billing stuff if there's ever an issue. Estimated body weight. I think this is important because sometimes it can drive your medication dosage selection. If your patient was 85 pounds, you could then give yourself some validity to why you maybe chose a smaller dose of an adult medication versus if your patient's 280 pounds, then they're like, why did you start at 200 joules to defibrillate them? Or why did you give them 100 micrograms of fentanyl 3 times? You know, it's right there. So let's just say that. Patient home address, 88 Smith Street, Barry, Vermont. Medical history. Let's just say they've had stents before. And, you know, I think stuff like this is important. I think at a minimum you should put what's pertinent to your call in here. And then if you wanted to write every single thing, oh yeah, I'm yawning again. If you wanted to write every single thing, then I guess go ahead. The only thing is sometimes people's medication problem lists aren't entirely updated. And then if you don't know that it's updated because you haven't done a scrub of the record because you're not a provider, you know, like a doctor who's involved with the patient's care all the time, then you might actually put stuff that's no longer applicable for that patient. Same thing with medications. So just, you know, keep that in mind. But I tend to put more of the medical history than I don't. So let's just say they have hypertension. You know, so they're 280 pounds. Let's just say that they're 5'7". So it's pretty self-explanatory. You could put obesity, and then let's just say they have diabetes. That's a pretty good picture to paint for because that's the common theme here, painting a picture. Could I review your run and say, yes, clinically, all this makes sense and it's reasonable. I'm going to use that term all the time, reasonable care. If you're operating within protocol and you provide reasonable care based off your suspicion and the patient's presentation, you're fine. If you need to go to the left and right a little bit and you need a medical control order and you get that, you're fine. It's when there's a recurring theme here, and that it's, did you properly explain why you omitted things and why you included things? So it's the property, or it's the idea of explaining omissions and validating your inclusions. Why did I do what I did, and why didn't I do what I didn't do? And if that's not explainable by your history, your assessments, and your narrative, then somebody who does the QA/QI process for your run is going to ask questions. And then when you say, "Oh, gee, SpongeBob, why are you picking on me?" It's just because your run doesn't make sense. It's nothing personal. Your run just doesn't make sense. So let's knock some of this stuff out of the way. Let's just say that this is easy. 4 miles, and let's just put in, like, I don't know, 2100. Oh, I said it was 3 in the morning, didn't I? Okay, 0304, because we're lazy. On scene at, I don't know, patient contact usually takes us, you know, unless somebody meets you at the ambulance, this usually isn't the same amount of time. It usually takes you a minute or two to get to the house and get gloves on and bring the necessary equipment, as well as a stretcher inside. You know, try to limit your scene time to 20 minutes is kind of like the national standard. It's not really like particularly written anywhere, but it's sort of this agreed upon EMS rule type thing that if your time takes longer than 20 minutes, you should explain why there were circumstances that led to that in your narrative. Was there a prolonged extrication? Was the patient difficult to access? Did it take you 6 minutes just to get to the patient? So you have to, again, that is something that if it falls outside of a standard, you have to explain it. And if you explain it, you're fine, as long as it makes sense and it's what I just said, quote unquote, reasonable. Let's just say we left scene at 03:28, 14 minutes, arrived at the hospital at 03:40. You know what? Let's just say we're stellar and we brought the patient to UVM. Oh, my little kitty's getting in the way. Let's just say even at 3 in the morning, we brought the patient direct to UVM, even though we want to go back to bed. And it's I don't know, 4:09 by the time we get there. Transferred care. Realistically, this is kind of hard to estimate. I would say just, you know, usually 5 to 10 minutes is about what it is, but you should try to make your best effort to be accurate with all of these times. And then also make all of these times coincide as best as you can, using good faith, obviously, with the time that your interventions are. If you transfer care to somebody at 4:15, but then you put in your report that you did an IV at 4:14, one of those 2 times is wrong. And if I'm reviewing your run, I'm going to say this doesn't make sense. Did you take the couple seconds or couple minutes? What's the difference between writing a run and having it take 18 minutes versus 24 minutes? And if the 24 minutes helps with the long-term goals of you, the patient, the documentation you provided, the transparency, the QA/QI metrics, all of that stuff, the QA/QI culture that I'm talking about, if taking 4 or 5 extra minutes made that benefit, then it's worth it. But that comes down to the individual having the integrity and the desire to ensure that there's accuracy and that the report makes sense. And then, let's say you have to go restock a bunch of things, so you're not back in service until 6 o'clock. Maybe you stopped at Dunkin' Donuts before you came back. Anyways, that's done. Look how much stuff. We're already 56% of the way down this call, and it's only been 8 minutes, and I have been blabbing half of the time. I would write this quicker if it was my own report. Do they take a statin? And then, I don't know. I almost never put medications here. If the medication is pertinent to the run, like a patient's having a hypertensive emergency and they ran out of high blood pressure medicine, or if a patient ran out of a steroid and they're having an acute asthma or COPD exacerbation, or a patient is in AFib and they stopped taking a blood thinner 2 weeks ago, I feel like those are clinically relevant medication things, which you should inquire about in your history if they're relevant, or you should try to. Granted, like I said, there's some limitations to this. If you're 2 minutes away from the hospital, you're not going to have time. If you're 45 minutes away from the hospital, you're going to have a ton of time to ask some follow-up questions. But also, depending on how severe the patient is, you might not be even able to ask them if they don't have a decent mental status. Allergies, obviously important. Let's just say for some reason they told you that they had an aspirin allergy, or they had an active, GI bleed or something. I guess wait, maybe call med control if you're ever. But let's just say that they are allergic to aspirin, and you don't give aspirin. This is huge because you didn't follow a protocol, technically, but you have to rule out or rule in why you didn't do it. You have to validate your exclusion. I said that as a theme, so let's keep going. Patient complaints. The reason, so this is a hard one sometimes, especially with interfacility transports. Your complaint for lift assist, that's a complaint. Transport is not a complaint. A complaint is chest pain. Duration of complaint, maybe you can't really, maybe they're just like, I don't know, I've had on and off chest pain for days, and that's all you tell you. You can't really write days. See, I just tried to write days. It doesn't work. This is a number. But notice how it's not red. So if you can't, let's just say that they have had chest pain for a couple of days, but they just say, I don't know, a few days, and they're vague about it. But then this chest pain happened so acutely and so much severe than it had previously that they say, okay, I've been having chest pain for days, but it woke me up in the dead of night, and now I can't take it. You have 2 options. You either can leave their duration of complaint blank and say in your narrative that the patient reports of generalized chest pain for a number of unspecified days. That's fine. Or you can say, they did have chest pain for days, but now they have an acute on chronic chest pain, and the acute phase of the chest pain is 30 minutes. And that's fine too. That's up to you. Location, chest. Cardiovascular, primary symptom, acute coronary, primary symptom, chest pain, suspected cardiac is what I meant. Other symptoms, nausea. Is diaphoresis one? Yep. And let's just say they had a little bit of shortness of breath. And let's just even say they had anxiety. Yeah. Working diagnosis. Acute coronary syndrome. And then I think you can even put STEMI if you wanted to, or you could put non-STEMI. I mean, if they have, that's a little bit harder because you can't draw troponins to do pre-hospitally, but let's just say it's a STEMI. Again, I don't want this to bing, so I'm going to delete that. I don't want the state people to go, oh my gosh, it's STEMI. I don't know, not applicable. I don't suspect anything. There's no odors. There's no cocaine or meth use. Other diagnosis, here's a little pet peeve of mine. Not a pet peeve, however, it's just something to be cognizant of. I think putting one diagnosis, if it's blatantly a STEMI, is pretty safe. I would say the majority of the time, it's likely it could be like 2 or 3 things. I like to kind of meet in the middle. I don't ever like to limit myself to one solid thing unless it's something like this. Multi-system trauma. Did the patient flip over on a motorcycle and break 6 bones? That's multi-system trauma. If you selected multi-system trauma as your only diagnosis, you are definitively correct. No question. Zero question. Nobody's going to ask you. STEMI, patient has chest pain, checks all these boxes, you are correct. However, if your patient has sepsis or an infection or pneumonia or COPD or something that you can't determine because you don't have the diagnostic capabilities pre-hospital, I like to like go in the middle, like maybe say 2, 3, sometimes even 4 or 5, depending on how kind of like ambiguous the call is. I had one recently where I wrote metabolic derangement, other metabolic disorder, some sort of overdose, misuse of meds. Yep. Sepsis, with or without shock. I think I said cardiogenic shock. Where is it? I did say this, and then I said STEMI, and then I said shock, cardiogenic, or unspecified cardiac disorder. So this patient had a lot of stuff going on. We're going to do a case review about it tomorrow, actually. But that would be an example of where, I mean, that's 7 things. That's the high end of what I do. I would say if you find yourself doing this, I clicked contractions. If you find yourself doing this, that's crazy. You might as well just click everything. You haven't really shown me or demonstrated in the QA/QI realm that you actually have the ability to do appropriate clinical, because your clinical suspicion. So obviously we're not providers, we're not doctors. We can't diagnose people. We can't say this patient has an occlusion of the right coronary artery. You could say suspect RCA occlusion based off where the ST elevation is. You could say chief suspicion, suspicious of, concerning for, coincides with, aligns with. You can say stuff like that, but you just can't definitively diagnose patients because obviously, like, we can't do that. The only things that we can do is we can put a trauma alert, a stroke alert, and a SEBI alert. The only time you really can kind of say what the patient is diagnosed with is if you're doing an inter-facility transport and you put their problem that they're going to the other hospital for, which has already been diagnosed by a medical provider. But I think that if you're using 15, 20 things here, you're kind of showing you're like, I don't want to say no shit, but kind of no shit, right? The patient has something going on. That's obvious. 98% of the time they call 911 because something's going on. So I think if you're putting just one thing, you better be really dang sure that it's one of these like no-brainers. I think if you're putting 20 things, you should reevaluate why you're writing so much. You should maybe narrow it down a little bit. Clinical suspicion matters because clinical suspicion is what guides your decision making. It's what makes your care either reasonable or unreasonable, and it's also what guides your decision to follow a particular protocol over another protocol. And protocol adherence is obviously very important. And even if you're not correct in what your presumption of the patient's chief, what your suspicion is, your field impression is, you need to follow a protocol based off signs and symptoms. And if you don't do that, then you're kind of operating out of the bounds of what is reasonably expected of any ordinary or prudent medical provider. So that being said, one working diagnosis, if you're very sure, I say somewhere between 2 to 5. Usually for me, it's 2 to 4, 2 to 3, somewhere like just a couple or a few. If I have something that's like multiple, I'm explaining in my narrative why this patient is so confusing and so complex. And that's it. So I think I've beat that to death. But it's important. So assessment. I always do an assessment when I arrive at the patient and I say what their stuff is. You have 2 options. You can either say that you remember that you did an assessment at 314 and then 317 and then 326. That becomes a little bit difficult to remember, especially when the patient's ill. So I don't ever recommend doing that if you don't have to. So I would recommend putting one initial assessment in and then just writing your narrative what the trends were. How did the patient change? Initially, I found the patient like this, I did this, and then this is how their condition changed. And we'll get into some ways that you can word that quickly and succinctly, and but also have it be meaningful in your narrative. So let's just say we do one assessment at the patient's onset. Normal baseline for a patient, you can click that, but you have to be sure that you know what the either a family member tells you, so you put that in your narrative. You say family reports that patients at their baseline mental status, or you know from previous patient encounters that they're at their baseline mental status, in which case you put in your report, per previous encounters with this patient, the patient presents at their normal baseline status. That's it. But I recommend that you do this if they're alert, if they're this type of medical patient and they're like, holy crap, I woke up and I have chest pain, and you tell if they're very coherent, chances are it's a yes for all of this. If you're like trauma, stroke, hypoglycemic, intoxicated type of patients, where you should probably ask these directed questions just to ensure that there's not a derangement in their mental status. Neurological status, that doesn't really apply for this type of patient, so I'm not going to get into it. I mean, you can read these. If you want to say that their speech was normal and you want to say that they're at their normal baseline because nobody's concerned about how they're acting neurologically, then do that. Head, face, I usually only put stuff there when the patient has like substantial trauma. If a patient has a little sliver, I don't think I'm going to put that anywhere. I'm just going to write in the narrative that the patient has a sliver and where the sliver is. But if a patient has their face blown off by a shotgun, you could probably say bleeding uncontrolled. I mean, asymmetric face probably, but that's not. Maybe they have an avulsion, and then maybe they have deformity, gunshot wound. Like that's where I would use face assessment. But for the real important ones for me, it's the mental status, it's the neurological assessment if they're a trauma or some sort of neuro or stroke patient, and then eye assessment becomes important for those types of patients as well. And then heart assessment, I don't think I ever put this in. I don't know. It doesn't really matter in my opinion. If the patient has a murmur, I don't know. I don't think I've ever filled something out there in my whole life. Chest assessment, again, if they have injuries, if they have diminished breath sounds on the left anterior side. Where is it? Breath sounds decreased. Anyways, that's not what this patient is. Lung assessment, if you listen to breath sounds, yeah, can STEMI patients develop heart failure and then have pulmonary edema requiring CPAP? Of course. If you're 3 minutes from the hospital and you're trying to get an IV and do serial 12 leads and get the patient aspirin and give them nitro and give them fluids, if it was maybe an inferior MI and they're a little bit hypotensive, or give them pain meds, then you might not have time to listen to their lung fields. But this is important. Bilaterally, let's just say this patient was full of fluids. So let's say they had decreased breath sounds, they had increased respiratory effort, and they had a little bit of bronchi, or Rawls rather. Oops. Yep. So let's just say that that's what the patient had. They were nauseous, but I don't know. And did your patient have an acute abdomen if they're a trauma patient? Distension, guarding, pain, tenderness. Yeah, that would do it. You should put that. I always do a skin assessment because this says, was your patient shocky or were they not? Skin, vital signs, mental status. Sometimes you can't get vital signs very accurately if the patient's moving, or if they're an unconsolable child, or if the blood pressure perfusion is really poor, your pulse ox doesn't pick up. But if you say that their capillary refill is more than 4 seconds, I do this on a lot of patients, a surprising amount of patients. It really doesn't take that much time. You can just ask your patient how they're doing, and if they know where they are, while you take a radial pulse, so you're assessing perfusion, and then you can say, hey, can I see your hand? Boop. You touch their finger, and then maybe while you're touching their finger and looking for their cap refill, you're like, oh yeah, they got a big honking vein right on top of their hand. That's where I'm doing my IV. look how much stuff you just did in 10 seconds. You know, and while you were talking to them, maybe you looked at their chest and you were like, okay, they're breathing faster, they're breathing slow. Your little quick visual assessment doesn't have to be super, super like, okay, now I'm going to test your deep tendon reflexes. So, anyways, let's just say that they're diaphoretic and they're clammy. And we'll say that their capillary refill is okay. Maybe it's not normal, but you say that it's less than 2 seconds. Do we want to say anything else here? Let's just say they're warm, so they're not like in profound shock. All right, that's my assessment. Vital signs, date last known well. I don't know if you're inconclusive about this. If it was 30 minutes ago versus day, unable to complete or not applicable. But let's just say it's happened 30 minutes before you got there. Ka-chow. That's done. Vital signs. I'm going to put in a time here. I hope that's not going to coincide. But you would just get this from your uploads on this little. If you're a trauma patient, I highly, highly recommend, or like let's just say it's a tachycardic patient. You should do weak or absent for their radial heartbeat. And then if it's an AFib patient, you should click this button. You should say that you palpated it if you did it on pulse ox or if you did it on the monitor. If you're a breathing patient, you should go in and you should say what this value actually was if you counted it or put it on end tidal. Respiratory effort. This guy, let's just say he's labored because he's got, you know, a little bit of edema. Maybe he's got left-sided heart failure. Altered mental status patient, you better put your glucose in there. As long as it's there. Like if you know, if you've got 18 sets of vitals and you took the blood glucose at set 9 but you accidentally put it in at set 12, who cares? Little things like that aren't the end all be all. I would say if you put it at the end and you treated hypoglycemia and then you say you didn't take a blood sugar until you were a minute from the hospital, that probably needs to be looked at. But that comes down to, did you make your report accurate? That comes down to, did you put a little bit more effort into the timing of your interventions to make it look like it flowed the way it actually did on the call. So if you know you did a glucose within the first 5 minutes, find a set of vital signs that was in your first 5 minutes of patient contact and put it in there, or put it in the narrative. That's all I'm saying, but it should go in here. Pulse oximetry, I should say this guy's like 91% at room air. Carbon monoxide, I don't know. I was busy. I didn't get it. Oopsie doopsies. This will populate automatically if you actually turn the button on. Pain scale, 7 out of 10. He's alert. Temperature, I don't know. Medical patients or environmental patients should always get a temperature. Certain patients with chest pain, you know, if they have pericarditis, they might also have a fever. That is an important thing to note. So let's just say, you know what? I'm just going to say skip the temperature on this patient. I had other stuff going on. Trauma patients, I think this is very important to put. And that's it. Vital sign comments. Here we go. Here's something that I always said. See, look at this. Look at, I've already put these. Vitals assessed on mine rate. That means I took them from CVMC. Prior to arrival, East Montpelier minor, GCS consideration, toddler with normal neurological. I don't even remember writing that, but I write stuff likely erroneous reading. I don't delete vitals because then it looks weird. I've had some transparency issues with that in the past. Not that I intended to do anything wrong or had any bad intentions, but you should leave your vitals in, and then in your comments, you should say likely erroneous due to patient movement. Again, just take the time. Stuff like that will help you if you ever need to validate your actions later in court or for a case review or anything like that. And then your narrative, say vital signs. Well, we'll get to the narrative, but let's just say I had a bunch of random vital signs here. I'm going to write it so I remember. Vital sign erroneous. Okay, we'll come back to that. Action. This is important. Protocols used. See, I clicked it once and it went away. It's no longer red. But acute coronary syndrome. And let's just say, I mean, maybe we did put this patient on CPAP. Is CPAP in here? I think it is. Ka-chow. I mean, it's BiPAP. But you can just write a comment in your narrative saying that you put them on BiPAP. Okay, Vermont specific protocol used. I don't usually fill this out. Yeah, I don't think I fill this out much. I suppose you could. Anyways, all right, protocols used. What else? Pain. I said they were nauseous. So this stuff's important. You should put this in because then when you do QA/QI and you get metrics, now these populates because when you build a report, you have to say the dispatch reason and then all protocols used. So if it's a stroke and then you list every single protocol there is in there, you're going to get way too many runs on stroke that aren't actually a stroke. So if you say, oh, well, technically your patient could have this 1 in a million shot, they could have this and it could be a stroke. Well, if you had 10 strokes in the year, now you have to sort through 200 runs and you didn't do yourself any good by compiling that data and performing the metric because now you've put too much junk into your inclusion criteria. So this is an important thing to consider, that when you're putting your protocols in, this helps guide QA/QI metrics right here. So put in the stuff that you actually did, but don't just put in 19 things because, I don't know, airway management. Did I sit the patient in the position of comfort at 45 degrees? Yeah. Does that really count as airway management? No. But did I put the patient on BiPAP? That might be airway management. So yeah, we'll say I put them on CPAP and I did put them on airway management. Procedures performed. This is very important. I always do the patient's arrival. I do an ALS assessment. I've gotten so good at this that I just, you know, um, it's very easy. Blood draw. Maybe we skipped this if we went to UVM. What else? The EKGs will come here, then you have to fix the red buttons. It'll say, did you who provided this or whatever. So for your 12 leads or your cardiac monitoring, you have to come and fill those red boxes back out, but it will automatically add the procedure for you at the time it was actually taken from your monitor, which means if your monitor is an hour ahead or behind versus daylight savings time and you check it in the morning, now you're going to go and you're going to be changing every single one of these by an hour. So keep that in mind too. Let's see, what else did we do? Pain, I don't think that's in here. CPAP, let's just say we put them on CPAP. Oops. Sometime on the way to UVM, we put them on CPAP. Successful, improved. Aha, improved. Complication, I don't know, maybe they vomited. That would be in here. Emesis, vomiting, ka-chow. Maybe you took it off. And then not applicable usually for airway complications. That's usually more for intubation or putting in a line insertion device. All right, let's see. Let's just say we did another IV sometime, maybe right before putting them on CPAP. Got 2 IVs and maybe in a cubital 16 gauge. Maybe we pulled over and got another provider and then Jackie rode in the back with me. We tag teamed this together. Yes, we did. Ka-chow. Medications. You know what? I hope we gave aspirin, but I said that this patient had an aspirin allergy, so that's okay. I won't put aspirin here, but let's just say the patient was a little bit hypotensive and we gave him IV fluids, but we were judicious with it. Oops, saline, normal saline. Let's just say we gave him 300 milliliters by the time we got to UVM. I don't know. And then let's just say we gave him fentanyl. 100 micrograms, improved. Then they vomited right around here. Remember, I put that procedure complication in there, so maybe we got around to giving them Sofran, and we know that they didn't have a prolonged QT because we looked at their 12 lead, and it's like 404. There's that. Let's say that their blood pressure is a little bit high. I mean, I know I said it's low. We gave them fluid. I don't know, whatever. I'm just hypothesizing here. Say it's a little bit high, and they're still having ongoing chest pain. So let's say after the first IV, before the CPAP, we put them on a nitro infusion. I'm a fan of a nitro infusion over. Let's just say we started at 50. Improved, and then if you titrated it 50 times, do you really have to go in there and say 50, then 55, then 50, then 60, then 45, then 50, then 6? I mean, maybe you could do that. That technically would be the right thing to do. But you could also just say titrated to maintain pain, adequate pain control versus goal map. Ka-chow. So what this tells the reader is that if your patient became hypotensive, you turn this down. If your patient's pain wasn't controlled and the patient complained of more pain, you turned it up. And then, if you ever shut it off during the transport, that it's important to note that time. But then let's just say by the time we get to the destination, we're up to like 80. That's important to distinguish, in my opinion. That's it. Titrated to affect and route final dose as described above. Whatever. I mean, like that. Really, just paint the picture. Just paint the picture. All of these will show up. You could go in and if you wanted to really scrutinize the 12 lead and say, oh, there was Q waves in the inferior leads with reciprocal depression and the high lateral leads in 1 in AVL. The patient had poor R wave progression, and they also had inverted T waves and SQ depression in V2, V3, V4. They had left axis deviation. Like, you could do that if you want to, especially if you notice that there are changes. If the patient developed a bundle branch block, or if the patient developed an AV node dissociation on the way, and then their PR interval went from like 0.14 to like 0.28. Oh, careful, kitty. Sorry. That stuff like that is important to note, but you don't really have to note that in here. I mean, it helps again for metrics, but just at least put it somewhere. Put it in your narrative or put it in here. Ideally, put it in both. Just make sure it's there. Immediate. We brought them in a stair chair because we didn't want them walking because we recognized they look like crap. They were puking and they're on CPAP the whole way. So Fowler's 45 to 60 degrees. We used our wee-woos. Hospital activations. Yes, STEMI. I don't remember at the time when I called it, but I looked at my phone and then I was like, oh, I called UVM at 3:39. The reason I didn't do it earlier is because I was like, oh crap, the patient's breathing bad and I prioritized CPAP. I don't know. Yeah, if somebody ever asked you about it and then you said the patient required CPAP and their airway was prioritized en route, kablam, you're covered. But I'm going to take this out because I don't want this, like I said, to get dinged by somebody collecting or analyzing data. All right. Destination, went to University of Vermont. It's a stroke, cardiac center, hospital capability, PCI capable. Billing, ALS level 2. I don't know. We gave nitro, multiple doses of fentanyl, whatever. Put their insurance information, blah, in here. Burpee, blah, blah, blah. Okay, that's in. Service defined. I don't know. We were coverage. Berlin coverage, maybe. They were down in Boston. What else do we miss? Signatures. If the patient's really sick, and go off to cath lab, get the hospitals, and then we'll put ours in. Ka-chow. All right, here's the meat and potatoes of this. So I'm just going to write a narrative for you. Residents for report of chest pain. Patient is a 64-year-old male with unspecified cardiac history, hypertension, stents, reporting vague chest pain over an unknown number of days. Oops. Worse 30 minutes prior to 911 waking him up at night. He presents to EMS with pale skin, tachypnea, diaphoresis, appearing in extremis, and appearing unwell. You could do something. Yeah, I'll use this stuff. I use it for all my appearing unwell. You could say sick or not sick here if you wanted to. Rapid vital signs assessed due to concern of significant or due to concern of I don't know, concerning story and patient presentation. Pulse was slightly rapid but strong, and regular at the radius. Respiratory rate was 30 to 32 with sounds of edema, or however you want to phrase it, with adventitious sounds suggesting possible edema. Patient, see, here's an important exclusion, denies history of CHF or heart failure. Okay, that would rule in, like that would make this make sense. Okay, patient endorses nausea, substernal chest pain, 7 out of 10. That is not radiating. That is important too. Patient denies abdominal pain. Abdominal pain, back pain, right? So like, if we're thinking maybe it's an aneurysm or something, and denies dizziness. So he has a strong radial pulse and he denies dizziness. Could he be hypotensive? Yeah, but that helps us say that maybe he's probably not. So if the patient did stand up and sit down, then maybe it's okay. Maybe he's not going to fall on his face. Okay, moving on. Initial blood pressure is mildly hypertensive. If it was 200 over 130, then we could say maybe this is an acute heart failure exacerbation. The patient's not in cardiogenic shock because the blood pressure's high, but maybe it's an acute heart failure exacerbation. Maybe the patient just needs immediate CPAP. SpO2 is 91% on room air. Patient endorses history of smoking 1 pack per day for 20 years. Aha, now what did I just do? I just said that 91, it's a little low. The patient is tachypnic, so there is an increase in work of breathing. But do I have to address this breathing problem right now, this second, or the patient's going to be an ultimate demise? No, because for a smoker, 1 pack per day for 20 years, 91 is like not horrible. Would that be bad if it was 89% on a non-smoker? Yeah, it would probably be pretty bad. We might need to address the airway a little bit faster. But let's just say breathing quality is tachypnic, otherwise normal depth and chest wall excursion bilaterally. Does my patient have a spontaneous pneumo causing the tachypnea and difficulty breathing and the sweating? Because that could do that, and it could cause chest pain. So anyways, we're ruling stuff in, we're ruling stuff out. We're painting a story. The patient vomits in the presence of EMS and maintains his own airway throughout. Does he need to be suctioned? I just said that they maintain their airway throughout, so no. Okay, good. Due to patient presentation, and inability to get stickers to apply to skin due to diaphoresis, along with stable blood pressure and SpO2 that is stable given patient history, rapid extrication from the house by a stair chair performed to acquire better access to patient for procedures and further care. At this time, additional resources requested for driver due to patient presentation. Patient moved to ambulance without complication and without, let's just say that. Placed in position of comfort, oxygen applied, which I didn't put this in the drugs. Oxygen is the drug. I would say, let's just say oxygen applied by NRB at 10 liters per minute with improvement. Actually, that's a little egregious. Nasal cannula at 4 liters per minute with improvement in SpO2 to 94%. However, patient remained tachypnic and overall work of breathing did not change. See, SpO2 improved, but work of breathing still the same. Rapid acquisition of 12 lead confirms anterolateral STEMI with reciprocal ST depression, T-wave inversion noted in inferior leads, or R-wave progression, transitioning by lead V5. Otherwise, sinus tach without noted ectopy. That's important. If the patient is having a bunch of PVCs, maybe you start to consider doing some sort of antiarrhythmic, or a fluid bolus if they're dehydrated, or magnesium if they're a known alcoholic, or tell you that information. All right, let's see, moving on. Then I'll spell check all this after. Without noted ectopy, no Barnum branch block or AV node dissociation. Appreciated. All right, serial 12 leads reveal minimal changes. See, this is important. Guess what I just did? I just did multiple cardiac assessments with one sentence. Your stroke patient, if they didn't change neurologically, just say serial or repeat neurological assessments unchanged from baseline. Or if it's only one thing that changed, unchanged from baseline, but grip strength to the left upper extremity improved. Okay, let's say it's a COPD exacerbation and you listened to the breath sounds 3 times. Respiratory assessment or lung assessment, unchanged in terms of adventitious breath sounds, but patient's respiratory rate improved from 32 to 24 breaths per minute by the time arrival at CVH. You just said that you did 3 or 4 assessments and you documented it in one sentence that actually provides you tangible trends in the patient's overall condition and or their vital signs. So that's a key thing to, with report writing right there. Ka-chow. 0 to 12 leads reveal minimal changes. Because could it change a little bit because of their position or because of lead placement? Maybe they sweated right through their leads and you have to put them all on, and now these lead placements are a little bit different. Maybe they're like, can I lay back a little bit? So you laid it back a little bit. all that stuff can change little minute details of the 12 lead. So minimal changes, are those changes clinically significant? Did they develop an AV block? Was their PR interval one way and then it was long again? So like stuff like that. Anyways, STEMI, patient urgently placed on CPAP due to progressive respiratory distress despite appropriate SpO2. This is important because the protocol says below 94%. For a smoker, it's below 88%. But this patient maintained poor lung sounds while maintaining crackles bilaterally in bases. So you just said that, okay, this patient didn't meet one little specific criteria because some textbook written 10 years ago said 94% was the magic number. However, you have just painted this picture that you said that the patient's breathing is bad and you know how to fix it. CPAP applied, initial settings, tolerated well at 5 millimeters of mercury. Patient positioning and mask placement. I don't want to say perfected. That doesn't sound like a good word. I want to say that they were idealized. I don't know. Patient positioning and mask placement. What do I want to say here? See, this is the thought that you should be giving your calls. You know what I mean? Like do good writing as well. Patient positioning. Oh, optimize. Yep, that's a good one. Optimized. Okay. Moving on. And respiratory rate was noted to improve on repeat assessments with overall status of respiratory condition improving. And notice that in the CPAP procedure, provider action, treatments, procedure, I said improved, not unchanged, not worse. And that coincides with what my narrative is. Pretty important stuff. Yep. Yeah, that's right. Okay. STEMI activation called as early as possible, but there was some delay due to cell phone reception as well as prioritization of respiratory status and the need for IV access and CPAP, or you could say non-invasive positive pressure ventilation. Let's see. Med control, MC. I'm going to make up numbers so it doesn't sound like I'm actually referencing a certain physician here, trying to keep this a little bit generic. Authorized direct transport to UVMMC, and given the adequate resources available, this patient was transported with 2 providers in the back. En route, overall breathing condition improved. 12 leads, unchanged, relatively unchanged. Am I going to waste time on this patient doing a posterior and a right side and all that stuff? Probably not. It's already a STEMI. We know it's bad. Unchanged. Blood pressure remains stable or within defined limits of the patient. Maybe they're a baseline hypertensive and 150 over 90 is their normal. That is within their defined limits. SpO2 remains above 94% on CPAP for remainder of transport. Because SpO2 goals are important for ACS patients. We don't want them at 100%, but we want them usually above 94%. Let's see. Now, would I want an SpO2, or sorry, a COPD patient being 96 to 98%? Maybe not. Would I apply oxygen on if a COPD patient was having chest pain and a STEMI, and they were 88%, even though 88 is the bottom end of the normal, would I still apply them on oxygen and get them closer to 92 because that's what coronary artery problems, prefer? Yeah, I probably would. If they're at 91%, would I put them on 1 or 2 liters? Maybe. So keep that in mind. For remainder of transport, let's see, chest pain improved from 7 out of 10 to 5 out of 10 with ×2 doses IV fentanyl, improving to 3 out of 10 after nitro infusion, titrated to maintain MAP blood pressure parameters along with pain compliance is better, along with patient comfort, pain improvement. Yep, there we go. I just, I did 7 titrations on the way. Who cares? I did my due diligence to maintain pain, comfort, and then kept blood pressure in mind. All right, moving on. Let's see. Secondary IV access established en route. And then what else did we do? Boy, maybe that's it. Patient stated he was going to vomit, mask removed, IV Zofran administered with the relief. The patient stated they felt better and mask reapplied. Patient briefly on basal cannula during this period without changes to respiratory status. Patient arrives to UVM MC in unstable condition. Moved to room 9. Report given to staff. Patient belongings left at bedside. Care is transferred staff or to UVMC. All right, that's it. That's my run. And then what I try to do sometimes, especially if my run is like really significant, is I'll go back maybe 12 to 24 hours after it, and I'll read this just to be like, does this make sense? Because other people are going to read it, and I kind of want to know if it does too. And then I'll do a reasonable thing of like going in there and using autocorrect to make this like sum look a little bit better. So I'll clean that up, ka-chow, and then I'll sort of proofread it after I do that. And then, probably I'll ignore some of these if it turns my run into something weird. Anyways, and then that's it. Then I'll save it, and then I usually will go in here and I'll update my time if I come back into it to when I because yeah, I did make those changes. And then if I know that other people are going to read this or if it's going to come a thing, I'll lock the run. There it is. Anybody can lock their run. Yep. That's it. Okay, I think that was a little bit long. Let's see, how long? 1 hour, 19 minutes. Okay. I'll change this to 1 hour and 15 minutes. 1.25. Oops, what happened? Oh, 1.25, count on to a period. All right. Okay, circling back to our objectives. Better understand the QA/QI process. I stated all that at the beginning of this rant. How to apply that process to provide feedback to others. Just be receptive, don't be defensive. Embrace the culture of improvement rather than thinking that people are out to get you. That being said, I encourage people to receive feedback well, but you can give feedback to people giving feedback. You could say, hey, I noticed that you gave me feedback this way. You wanted to do constructive feedback for me, but you didn't actually give me a tangible outcome to improve on. You just said that I needed to do better, but I actually don't have any goals to do better because you didn't give me anything to go on. Next time, would you mind saying, hey, I noticed that you waited 15 minutes to get a 12 lead. It's better with a patient that's presenting with chest pain that you try to get a 12 lead as early as you can, usually within 5 minutes of patient contact. If you did wait 15 minutes to get a 12 lead, it would be helpful for you to explain it in your narrative, because maybe that's all they did. Maybe they said, oh, well, the patient was in a pool and we needed to get them out, and then they fell on the way out, and then we had to pick them up and make sure that they weren't injured. That would explain why you didn't do a 12 lead in 15 minutes. And is a patient entitled to develop chest pain while they're in a pool? Yeah, absolutely. So you could provide feedback to those who are giving you feedback about the way they give feedback. And then also report writing tidbits of how to improve the QA/QI process. To highlight a couple of things. I forgot to say let's see, note, various blood pressures were likely, I'm not saying they were erroneous, due to patient movement during the vomiting, retching, I don't know, nauseous period. Blood pressures overall not unstable or trending for this provider's interpretation. Whatever, something like that. You know what I mean? You're like, okay, the blood pressures were weird for a little bit, but the patient was vomiting. Yeah, and you were bumping down a road, and then it said your blood pressure was like 190/80, and then it said after that your blood pressure was 90/50, but then every blood pressure after that was normal. That being said, if you have a really weird blood pressure on the left and the right, make sure you get some to validate that that's correct or not. Like if you have one that's 60/30 and then one that's 200/100, and those are the only two sets of vitals that you took, that's weird. Take more and then just say which ones were weird and then say which ones you believe were correct based off patient mental status, patient skin condition, and overall patient appearance. So I think we met those goals pretty well. Some tidbits, like I said, depending on your proximity to the hospital, severity of the patient, the type of call that it is, there's ways to. This is a little bit of a long report. It's a STEMI, and then I would sign it, obviously. Here we go. Ka-chow. Done. All right, so that one took me an hour, but that was with all the explanations of everything. So this is like this, 20 to 30 minutes to write a report like this, and it's like a decent, juicy report with an hour and a half of patient contact time. So that's if this was like a mass casualty incident or something even worse, maybe it only takes me 40 minutes. But by and large, all these take me 15 to 20 minutes, even with explaining it. An hour to write a report, yeah, that's a little bit long, especially if you do 6 calls a day, because that's 6 to 12 hours of patient calls and then 6 hours of paperwork. So that could get pretty burdensome. But doing due diligence on a run report really doesn't take that much effort. And I think we owe it to the process to do stuff like this. It makes my job easier, it makes the QA/QI process better, and then it makes it so we can provide better training, but that requires that people put this effort in. They also remain faithful and honest to the best of their ability. And then they also put the effort in to make sure that their times align. Like it doesn't make sense if you say that you give patient nitro before you put an IV in. So if you just go back and just carefully kind of proofread your stuff, especially if you're really tired and it's the middle of the night, just go back. I'm not going to look at any run before it's done for a day. Or if I do, it's totally a preliminary investigation, and then I'll go back and then I'll re-download it because people go back to runs. Little things. Make sure your run is signed. Make sure that if you're using it on somebody else's tablet, if somebody else is logged in and you're just using the tablet on somebody else's account, which happens all the time, that you put your, let's say Jackie wrote this and I logged on and I was like, hey Jackie, you want to tech it? And she's like, hell yeah, I want to tech it. I'm the STEMI cardio version freaking champion of Berrytown this year. Just make sure you put, stuff like this. Yep. Okie dokie. And then the hospital signature would be in here too. Hospital receiving agent. I don't know. Jane, Janet, now signed. Okay. Alrighty. And like I said, hopefully David could delete this. I'm going to say requires review or deletion. Okay. Thanks, everybody. That's it. Please let me know if you have any questions.